Welcome, welcome everyone. I see as we're coming in. Hi, Dwayne, Megan, Tasia. We have a few more. I think Kate's out there. Got Alexandria. Love seeing all you guys coming in tonight. I am in Florida, so as many of you may be following the hurricane, some of us are underwater here, so we do have Dr. Wilkerson's recording tonight since he's a little bit underwater, so just kind of know that. We'll talk about that. Those of you who know him, love him, maybe drop a little text that you're thinking of him tonight. As there was a big water surge and flooding going on, but the great thing is we're all healthy, we're all alive, and we are just so grateful for that. I see a few other of my friends. Shout out to Dr. Reisinger. Miss you, love seeing you on here. So Dr. Pritchard, we are just more than enthusiastic about what we're going to be sharing with everyone tonight. I want to just start talking about that. We've been brainstorming, talking about our mission and vision that we share with many of you. And really, we want to start forming this community, this elite community, and share with you one of your famous sayings. You say, are we really serious? What is that, Dr. Pritchard?
We're interested in others who are serious, not just curious about implementing oral systemic collaboration.
So drop me a note in the chat over there if you're serious or if you're just curious, because obviously if you're still just curious, you are more than welcome, because we've got to start with curiosity. But we know many of you are beyond the curiosity. You do understand the oral systemic connection and you want to become more serious. Yay, Tasia, thank you. I know you're serious. One of my serious collaborators out there. Got a few more. Dr. McClatchy's serious. We know that, starting to collaborate, working on that. And so this is really one of our big missions, to quit serious. Those are all my girls out there. Yeah, we're gonna give you some kudos. They've got a little, I'm gonna call you my hygiene posse out there. They're forming strength in numbers. So I hope as my MDs come on, you guys start to form this community and get to know each other. That's the other thing about becoming care coordinators, is that it's strength in numbers. We cannot do this alone. We know that it's beyond just one person in their silos. We need to help each other, collaborate with each other, share our knowledge so that we can take on this mission to really change healthcare. Dr. Pritchard, just share a little story about today, and then we're going to get started as more people are coming in. But really, today was a great reminder, this whole week as a care coordinator. But we were just talking about how important it is, the job that really care coordinators take on.
Yes. So we've had more than one patient this week, several actually, that the more that we do this, that I begin to think, one, how incomplete my care was in years past when I would simply give a patient a referral to see the dentist, if that. And now that we've been collaborating together for several years, and we actually have a total of 3 care coordinators on the team, Laura Hooper, the dental hygienist, care coordinator. Then we have a nurse and a phlebotomist medical assistant. And so what I've realized this week, because of some of the cases that we've had, is every medical team needs a care coordinator, care coordinators, and at least one of them needs to be a dental hygienist. And the reason that that's true, and the reason that this oral systemic collaborative movement and community that we're building is so important, is because I can think right off the top of my head of 3 patients, but you and I were talking about the one earlier today, that had I seen him in years past, I would have done a great cardiac workup on him, and I would have done in-depth lab work, but I wouldn't have known what his saliva test showed. I wouldn't have known if he had sleep apnea or desaturations at night or not. I might have sent him for a referral to see a sleep doctor, but I probably wouldn't have, because he's young-ish, thin, works out, eats clean, we didn't have sleep apnea or even desaturations, or is oxygenation ideal all night long? We didn't have that on our radar as a major root cause for heart attack and stroke. So the list goes on and on. When we put together our care plan with all of the tests that we run, that we're teaching everyone about in this community and teaching what to do about them, the care plan just becomes so inclusive, so all inclusive. And truly, we can guarantee that there's the best workup on the planet in terms of saving someone from heart attack, stroke, and vascular related dementia in the future. It's so exciting. And I really can't wait until we see 1,000 collaborative practices, and 10,000, and then 100,000. I mean, we need so many because everybody needs access to this collaborative care. I know those of you listening realize that, but it's just been so apparent to me and Laura as we've had a lot of patients this week, but in preparation for tonight, it's like, yeah, I would have missed this. I would have missed that. Who would I've talked to about X, Y, and Z? Yeah.
And so that's really what OASIS is all about, the oral and systemic integration system. And that's really what our whole program will be, is about sharing that system, walking you through the process. And we're going to share that with you. But right now, we're going to get started. You're going to hear our videos here. And then at the end, I really want you to think about what questions you have. Those of you who are like, I want to start doing this right away. Really, the biggest piece, you're going to wait till the end because you're going to hear about it. You're going to see that blueprint. And then we're going to talk about what makes the difference for integration into the practice. So Dr. Pritchard, take it away.
Okay, so first you're going to see the video that Laura and I recorded. And then after that, we're going to go to the pre-recorded video that Dr. Wilkerson recorded for y'all tonight.
Dr. Pritchard?
Sound.
Yeah, we need to go back.
Where we eradicate infection. Okay.
Sorry, you have to stay unmuted.
All right. Sorry, y'all. Let's go take 2. How many of you want to wake up every single day inspired and fulfilled to eradicate infection and inflammation? That's the beauty of our collaboration, where we eradicate infection and inflammation for our patients using these improved measures and tests and treatments that we have in order to save and improve our own life and the lives of our patients. So tonight, we want you to discover the solution to what we believe is the single biggest challenge oral and systemic practices face, both medical practices and the dental offices as well. And a little hint is that the problem is we do not have a system. I don't know if any of you can relate, but I know when I first started out, I felt confused in this oral systemic world. So we want to help you go from confusion to confidence with the Integrative Dental Medicine Scholar Society OASIS program, the Oral and Systemic Integration System.
And so I started just like all of you, just as you were saying, Dr. Gina, we kind of start in this confusion, and it's really about a transformative journey. That's what OASIS is about, is creating a system that you can be on your own transformative journey from confusion to confidence. And for me, it was hygiene confusion, being a hygienist, to going to a collaborative care coordinator. But the 3 biggest areas that kind of, I think, bog us down is these 3 hygiene confusions. We get confused with what a diagnosis is, what the best treatment, and what are the best products. In fact, when we look at hygiene confusion, the first one with diagnosis, How many of you were like me? We were actually taught to just look at bleeding and pocketing. It's kind of like we're trapped in this diagnosis. But what is the root cause? So let's take a look at the science. This is where some of the confusion is. We're kind of trapped in this confusion because of what we're taught. But when you look at this study here, so take a look at that graph, they're showing you that red zone pathogens, the ones responsible for bone loss, are there in as little as these 1 to 3 millimeter pockets. In fact, if you look on that 3 millimeter line, look at that. Those red zone pathogens are taking over at 3 millimeters. So confusion, why am I taught to wait till I see a 4? This is why we have to get clarity around that. Well, the same thing happens with bleeding. We're taught to wait for that bleeding. And so take a look here, getting clarity around the science is that you can look at the red, the orange, and the green. Look at that 30%, we can see these red complex pathogens are there even when there's not bleeding, and they start to take over well after that 30%. So this is why we're so confused. We need to look at what's there microbially. We need to get to the root cause and not be confused on what we were taught in diagnosis. Well, how about with the treatment? Treatment confusion. This used to make me pull my hair out. In fact, I was taught to clean them up. I was going to make them better, do that scaling and root planing. And our literature shows us that it fails to eliminate the pathogens. It fails to stop them from entering the bloodstream, from us swallowing them crossing the linings in the body. In fact, it tells us that these pathogens return microbially in as little as 3 to 7 days. Well, no wonder why I was so confused with my treatment. It makes sense. In fact, we talk about antibiotics. That's another treatment confusion. Should we use them? Shouldn't we use them? And we know that we have to clear these biofilms and get out of confusion. So it relates to our third one, which is product confusion, is that we learn about all these things. We just start throwing all these products at our patients because we're confused. We're not looking at what's there microbially and what products will actually be the best one for that patient. In fact, I'm sharing some of the confusion with you tonight is that there's this huge emergence of antimicrobial resistance because we've been confused just giving our patients all these harsh antiseptics. Look at those ingredients. They're in many of the products out there. And these types of bacteria can actually mutate and actually cause resistance, which we're seeing now across the United States. So we have to step out of confusion, look at what's there microbially, understand our root cause to infection, to bone loss, to bleeding, to all the signs and symptoms we see are really to look at with better measures, see what's there microbially. So we want to teach you how to at least get tonight, look at some of the clarity that you can start to step out of confusion, or like me, just acknowledge, wow, I was in confusion and I'm ready to join this journey to learn how to gain the confidence to learn how to collaborate. But the same thing was happening with you, Dr. Gina, correct? On the medical side.
Absolutely. So when I began to hear about the oral systemic connection and the need for collaboration, began to understand that there was and is research out there to support this need for collaboration between what's happening in the mouth and what I was seeing in the hospital with heart attacks and strokes. I didn't know where to start. I was confused. I knew the research was there, but I didn't know what to ask my patients. I didn't know what to test for, what to ask my dental colleagues, exactly how to get started with all of this. And I too had the three biggest areas of confusion revolving around diagnosis and treatment and products. And Laura, you and I couldn't articulate that at the time. We were both going through this on our own world, in our separate worlds back at that time. But looking back, we realized that that's what we were struggling with, is how do we diagnose this? How do we treat it? And what products are necessary? So with regard to diagnosis confusion, in the hospital, we were opening up blood flow when there was a 90% blockage, 100% blockage, a 70% blockage in a heart artery, in the coronary artery, when the person was having a heart attack. So we became fixated on blood flow. Let's reestablish blood flow at all costs, fix the blood flow problem, and then send the patient home. But now we know that we were confused. We didn't admit it or even know it at the time, but now we realize that's only the crisis problem. The long-term problem is that plaque description in those smaller areas of plaque is crucial, not just blood flow. Once we save the person's life in the crisis moment, then we need to know what type of plaque is there and describe it so that we can know from one test to the next, from year to year, if we're reversing the disease process by improving the composition of the plaque, if you will. And secondly, we all know now that inflammation is the driver of all chronic disease. But at the time, I knew that, but I had no idea you could test for it and actually know if the person was becoming more inflamed or less inflamed. Now I know we have blood tests, we have urine tests to understand where a person stands in terms of inflammation, and that inflammatory test or inflammatory lab panel is more predictive than a stress test for a person with a future risk of heart attack. And then thirdly, of course, diagnosis confusion around the mouth, putting the body at risk. I knew the research was there, but I'm like, how do we know if that's happening or not? And that's where I began to identify that I had confusion in that area and needed clarity about exactly how does this mouth connect to the body and how do we diagnose that connection, the problem there. So this is just an example of what I was talking about previously. When we look on the left side of the screen at the coronary artery in 2010, at the top of this CT scan result, we can see adequate blood flow with a little bit of yellow plaque. That's a moderately risky plaque. 7 years later, not only is there an impairment in blood flow now, a blockage, but this plaque, you can tell by the red, by the increased size of the plaque, and now this red is just a color that's been applied to a dangerous component of the plaque. So now this has become a plaque that's dangerous, that's volatile and vulnerable, and it's gotten worse and impeding blood flow. So this is one example of how we can get clarity with our testing to know if what you're doing in the dental office, Laura, is improving, harming or hurting. I mean, harming or helping our patient, improving their coronary arteries or not. And how I can tell if everything that I'm prescribing and offering and teaching in the medical office is doing the same, helping or harming. And then in the middle is an inflammatory panel, like I spoke about earlier, where we can see, is this person getting more inflamed or less inflamed over time? And then on the right is an ultrasound of the carotid arteries to tell us the same information. Are the arteries getting healthier? Or are they becoming worse? Secondly, in the category of treatment confusion, in the hospital, and before we knew about the oral systemic relationship, we were seeing the blockage, opening the blockage, prescribing a procedure such as stent placement, prescribing pills, and sending the patients home. And we realize now that leaves them at tremendous risk because it's a very single-focused reactionary type of approach, rather than teaching the patient holistically and integratively between the dental office and the medical office about lifestyle, about breathing and loving relationships, about eating. What are we eating? What's our nutrition like? Stress, sleep, exercise, all of the lifestyle, wellness, and biohacking aspects of life, as well as then the D in the acronym BLESS, which brings us back to diagnosis. Always testing and retesting to refine our care plans or in our collaborative efforts. And then to product confusion. Previously, I would work for corporations or with contracts with insurance companies where the protocols were mandated for 70% of the population, X, Y, and Z, and following protocol A, B, C, and D is best. But now we know that that's not always what's best for the individual sitting in front of us. Through the use of genetic testing and epigenetic testing, we can refine and customize our product, our supplement, our lifestyle, our biohacking recommendations for the patient sitting in front of us and that individual needs, not just the majority of the population. So Laura and I, we want to guide you. Laura and I and Dr. Wilkerson, we want to help you avoid some of these pitfalls and barriers that we've worked our way through, avoid some of the mistakes, and go as quickly as possible through the 5-step process from confusion all the way to confidence and then ultimately to collaboration. So what is the clarity blueprint? The clarity blueprint in the OASIS system. So the clarity blueprint starts with, as we've just talked about, first identifying there are areas of deficit in our knowledge and areas of confusion that we need more information in. What are those areas? Secondly, understanding those tests that need to be ordered on our patients. What do those results mean? And then coming together to merge our treatment plan based on those test results. Then level 3 is where competence starts to form. Once we see that our collaborative care plan is making an improvement in the follow-up testing for the patient, we begin to feel more competent in what we're doing, which leads to confidence on level 4. Once we have 3 or 4 or 5 or 10 or 20 patients that are becoming healthier, their lab tests are improving, all of our collaborative testing on either side of the aisle, each side of the equation, if you will, are improving, then we start to realize, okay, now I feel more assurance in this protocol that I'm following, in this system that I'm following. If I'll just follow the system, then I can see improvement in my patients. Not that we won't hit a hiccup along the way. What the safety net is when you follow the system, if you do follow-up testing and you don't get the result you want, you can simply tweak your care plan, adjust, refine the process, and retest again in 3 months to make sure that patient is constantly moving towards health and away from disease. And that's the 5th step where collaboration begins to be very exciting, doesn't it, Laura? Where we feel some mastery in terms of integrating our medical and dental knowledge to optimize the health for our patient. So next we want to listen as Dr. Wilkerson walks us through this transformative journey, the 4 C's to mastery, or the 4 C's to oral systemic collaboration. He's going to give us a lot more detail around confusion, clarity, competence, and confidence, and ultimate oral systemic collaboration using the OASIS system. How many of you want to wake up every single day? We don't need to see that again. We need to move on to Dr. Wilkerson. Here we go.
As we continue our masterclass in our transformative journey, I want to share with you emphasis that we have been focused on, and that is the 4 C's of mastery of oral systemic collaboration. The first C is we start in a place of confusion. I don't understand this at all. And secondly, as we do begin to look at the research and understand what's true today, then we can obtain clarity that hopefully will lead us now on a path toward competence and care for patients and ultimately confidence in what we're doing. So let's start with confusion. That's always a good place to start, isn't it? And the question is this: what complete health issues should dentistry or oral medicine address? I know many of us, particularly on the dental side, are not sure where we fit into the bigger equation of total health. And so I'm going to pull up just a few articles just to give us context and to stimulate our thinking about how central oral medicine and oral health is in the bigger picture of systemic health. The classic article written by Dr. Bale and Doneen and Vigrist in the Postgraduate Medical Journal in 2016 talks about how periodontal disease generated by microorganisms can cause a bacteremia in the general circulation that can have adverse systemic effects, including cardiovascular disease. And there's strong scientific evidence that supports this fact that periodontal disease is independently associated with arterial disease. In the article, they go on to cite 5 specific high-risk bacteria, AA, PG, TF, TD, and FN, that are the drivers of this bacteremia. And they are labeling it as an inflammatory cascade. We're going to use that word over again and again, that phrase, inflammatory cascade, because it's inflammation that drives chronic diseases in the Western world. This is one of those sources of major systemic inflammation, and as is stated here, as a contributory cause of atherosclerosis. So the conclusion of this article is distinguishing this type of periodontal disease as causal provides a significant opportunity to reduce arterial disease. So you see the oral and systemic connection here. In other literature, look at this. This is the Journal of Internal Medicine. And it's talking about periodontal disease being associated with carotid plaque areas. Down at the bottom, you see circled, it says a person with periodontal pockets is expected to have a larger carotid total plaque area. So there's a direct relationship. Here we see other articles from medical journals talking about how FN increases the permeability of the lining of the arteries and lets other bacteria enter the arterial wall. And that in the arterial wall, they're actually finding these 5 high-risk pathogens present in very high concentrations. An article out of Finland in 2013 published in Circulation, a classic by Pessi and group, talks about 101 acute heart attack patients where they found that the DNA load in the blood clot, the thrombus of their heart attacks, which were retrieved, were 16 times greater than in the surrounding arterial blood. And they were 78% of the blood clots had streptococci from the mouth, and 35% have periodontal pathogens from the mouth. They also found that about 50% of these subjects or patients had one or more abscessed tooth, leading them to conclude that dental infection and oral bacteria are associated with the development of acute coronary thrombosis, that is heart attack, and that dental health and dental care should be one major element in preventing heart attacks. This is so insightful. I wasn't aware of that for so many years, and now we know that leaky gums and leaky arteries are connected with each other. As we go on, we look here now at the gut, and we hear a lot about the gut these days, don't we, through research and science. But if you look at the upper right-hand corner where it's showing leaky epithelium or lining of the guts, then what you see circled in red, it says bad bacteria. Guess what those bad bacteria are? They're the same bad bacteria that we see as the big 5 in the mouth, now swallowed over 1,000 times a day and going down into the GI tract. And you can find all sorts of illustrations all through the internet and in research showing this, and articles that are showing us that it's a pivotal role of leaky gums analogous to leaky gut. And it underscores the importance of the oral cavity in systemic health. So we're going to add to this equation and say, yes, leaky gums are important to leaky arteries and to leaky gut as well. And then we talk about diabetes. We know that diabetes has been described as being like having shards of glass scraping the walls of your arteries all day long. I would propose that having periodontal disease can have a similar effect. And as we look at these two together and begin to read about them, we've heard that they're bidirectional, meaning that diabetes can influence periodontal disease and periodontal disease can influence diabetes. And so we looked at the literature and we began to find absolutely that's true. The literature is replete with articles that explain exactly the mechanisms by which that happens and how important that is. What about brain health? We've been hearing more lately that oral pathogens, that oral periodontal disease pathogens can be related to Alzheimer's. Is that really true? I'm confused. Well, if you start to look at a little bit of the literature, you begin to find out that exposure to chronic periodontal disease quadruples an individual's risk of developing Alzheimer's. And there's lots of articles that talk about how these oral pathogens, bacteria, can pass through the blood-brain barrier and stimulate cells in your brain that normally are used for anti-inflammation, but now they're occupied with dealing with oral bacteria that cross the blood-brain barrier. And now we find that we can develop literally leaky blood-brain barriers that's related to Alzheimer's disease, and that identifying the impact of oral bacteria on brain cells and neuroinflammation is a critical part of targeting therapies to prevent the infectious inflammatory processes that exacerbate Alzheimer's disease in humans. And so now we see, well, sure, leaky guts are important to leaky arteries and to leaky gut, but now also we see important for leaky brain as well. This is so intriguing. And what about airway? We're hearing a lot in dentistry and oral medicine about airway and breathing, and sleep apnea has become a big subject in dentistry over the last 8 to 10 years. And what's that all about? Well, some work has been done going way back to the 70s and 80s at the University of Michigan Human Growth and Development Center. And one of those studies was done with Dr. Harvald there with rhesus monkeys. And what they found was when they put silicone plugs in the baby monkeys' noses, they would convert to mouth breathing, and they would end up with long, narrow faces and dental occlusions, malocclusions, sometimes tongue thrusts, exactly like we see in our orthodontic patients among humans. And so we're learning now that our facial structure and growth is largely influenced by our breathing. And when our nose is obstructed and we breathe through our mouth and our tongue takes a low posture and a protruded posture, and it doesn't fill the vault of the maxilla, we're going to end up with crowded teeth. We're going to end up with tongue thrusts. We're going to end up with malocclusions. We're going to end up with TMD, temporomandibular disorders, that is discomfort in the head and neck region that can be related to muscles and clenching and grinding and bruxism and headaches and joint issues, all can be related to this subject of airway. McNamara, who headed up the Human Growth and Development Center at Michigan, concludes almost 20 years of their research on this subject by saying there's a relationship between upper airway obstructions and undesirable dental and craniofacial development. Significant improvements are seen when the obstructions in the nasal area are removed, when nasal breathing is reinitiated, when the mouth is closed on breathing, all of these things. And so this is news. This is important news that we never understood. There were studies now all over the place. This is one from Europe with 71 oral breathing children ages 6 to 12 compared to 71 nasal breathing in the control group. And what they found was a strong correlation between oral breathing and malocclusions. And what they concluded was this is a self-perpetuating vicious cycle, which has to be addressed. And it includes the pediatrician and the ENT and the allergist and the dentist. And so here's the team that's addressing some of these very serious problems. The literature on the internet is full of the oral systemic, of the oral medicine, whole health connections. Look at this from the Cleveland Clinic on their website for the public. People who breathe through their mouth and not their nose are more likely to develop sleep disorders, including sleep apnea. Children who have mouth breathing are more likely to have dental problems like malocclusion and facial differences. They can also develop obstructive sleep apnea that healthcare providers link to learning difficulties and behavioral problems like ADHD. And so on this site, look at the things I'm circling in red: enlarged tonsils, dry mouth, bad breath, malocclusion. These are things that the Cleveland Clinic are pointing out to the public that are very important things that are often related to mouth breathing, that are often related to airway problems, sleep problems that may be present. I look at this and I think about dentistry and oral medicine, and it's sort of like, hey, look, everyone, the Cleveland Clinic has teed it up for us to be able to address these serious concerns with our patients. Are we? Do we understand it? Are we still confused? Are we caught in a place in which we don't know the answers because we don't have clarity on why these things are? And yet it's time, because the public is crying out for help in these areas. The information is available, and we need to really begin to learn these things and begin implementing them. Dr. Christian Gimeno is a renowned pulmonologist who is really known as the father of sleep disorders. He coined terms like sleep apnea and this term, upper airway resistance syndrome. He coined this term when he was studying young, thin people who would come into his medical practice with severe fatigue and poor sleep, but did not have obstructive sleep apnea. They did have multiple partial to total breathing obstructions, but they weren't severe enough to be called apneas, but they could lead to arousals from deeper sleep to light sleep, interrupted, fragmented sleep. And so he did a bunch of studies. Here's one where he took 30 subjects that he did a polysomnogram, that is an overnight sleep test in the hospital, and they were all diagnosed with upper airway resistance syndrome. Look at their symptoms. 28 reported non-refreshing sleep. 26 said their sleep was disrupted. 17 reported morning headaches. That should be familiar to every dentist. 29 reported daytime performance impairment. So the question I have is this TMD or is this upper airway resistance syndrome? If you ask Dr. Gimeno, if the classic TMD patient came in to see him with sore muscles, bruxism, fatigue in the morning, headaches in the morning, what would he diagnose them as having? He would say, that's classic upper airway resistance syndrome. And so here's an example of a young lady who might come into a dental office saying, I've got sore muscles, I'm tired. And we in dentistry historically would probably want to make her an appliance. But let's follow her home tonight and watch her sleep. When we sleep, we should be breathing through our noses. She's clearly a mouth breather. We should be breathing calmly and deeply from the diaphragm in the lungs. But she's breathing from her chest and very shallow. She should go from light sleep to deeper, more sound sleep. But you can see she's gasping. She's having trouble getting air into her lungs. She's having arousals from deeper effort to go into deeper sleep, to back to light. She's moving her arms around, trying to find a position where she can breathe. And so if she came in to see you and said, I wake up and I feel horrible, my jaw's tired, my muscles are sore, I've got headaches, the average dentist, the typical dental treatment would be to make a splint, an occlusal splint. But we've learned now that an occlusal splint may actually make her problem worse, because if you can't breathe and you don't have enough room in order to breathe, does it sound like we should be putting more things in your mouth, such as a piece of plastic? Maybe not. And so the question should be, these quote unquote TMD patients, is this: could there be an airway problem? We need to find out. And so we move on and look at this fascinating information from the medical world, from the world of pulmonology and sleep medicine, where as we look at this graph published by Avram Gold in the medical journal Chest back in 2003, you see these different bars, and the white one is upper airway resistance syndrome. The other one that's black and then slashed is mild to moderate sleep apnea and severe sleep apnea. Look at what we find as far as the prevalence percentages of headaches. The highest percentage of headaches among these three groups is among those with upper airway resistance syndrome. Over 50% reported headaches. Irritable bowel syndrome, over 40%. Bruxism, over 50%. Depression, over 30%. Gastric reflux, almost 50%. All of those have explanation for why they would be true as related to diminished oxygen and breathing capacity during sleep. This is something that most of us never knew before. Another connection between breathing and airway and sleep is gastric reflux. So we know gastric reflux can be associated with heartburn and regurgitation, coughing, chest pain, swallowing issues, sometimes vomiting, sore throat, and hoarseness. Those are common symptoms and signs of gastric reflux disease. But what I want to point out here is that gastric reflux has increased by more than 77% over the past 10 years. The first group that is most likely to identify the signs of gastric reflux is the dental community, whereas you see on the upper left-hand screen the severe erosion on the teeth that is chemical in nature because of severely low pH, where you see cupping out on the occlusal surfaces and smooth wear on flat surfaces like the facial and cervical areas. And that's an increasing problem, but it also is highly correlated with sleep apnea or airway obstruction or upper airway resistance, because where GERD appears to increase the risk of obstructive sleep apnea, so it is that the increase of obstructive sleep apnea contributes to the development of gastric reflux. So this is a very serious medical problem. The fastest growing incidence of cancers in the United States today is esophageal cancer, and it's directly related in many cases to the problem of gastric reflux. In fact, there's two types of esophageal cancers with different risk factors. One, adenocarcinoma, is known to be directly related to chronic acid reflux, leading to gastric reflux, leading to chronic irritation of the esophagus called Barrett's esophagus, and chronic heartburn that can then lead into cancerous outcomes. The other type of esophageal cancer is squamous cell carcinoma, and that's highly associated with heavy alcohol consumption, smoking, and organ transplants. But you see how the environmental influences, again, are very, very important. And so one of the things that I'm most excited about is to be collaborating and learning from Gina Pritchard and Laura Hooper. They have been putting something together that is going to be revolutionary in the whole world of science and medicine. They'll be publishing articles in this coming year on this in journals, talking about the role and relationship between airway, oral pathogens, and plaque in the arteries. And in fact, seeing that when there's airway disruption, you change the environment in the mouth, the pH in the mouth, to the point where anaerobic bacteria flourish. And when anaerobic bacteria, which are associated with our 5 big pathogens, are flourishing, you get more leaky gums, and you get more leaky arteries, and you get more leaky gut, and you get more leaky brain. And so I'm so excited for the work that they're doing and some of the things that they're showing us about airway and some of the signs and symptoms that we can look for when the airway is not functioning properly, and getting to know these 5 high-risk pathogens, the big 5 as I think of them, those that are known as the keystone pathogens, or 4 of which are known as the red complex pathogens. These are something that everybody in medicine should know about, and everybody in oral medicine should be directly testing and working with on a daily basis. And then finally, what we're learning about plaque, and Laura and I have been learning so much from Dr. Gina about this, as we're coming from a dental perspective, and she's bringing back to us from a medical perspective where inflammation intersects between the oral and systemic systems, all of which, of course, are one big system. And so these are the things that we're learning, and all part of the inflammatory cascade, which can come from different directions, adding up to something that we call inflamed aging. That is accelerated aging caused by systemic inflammation. The key thing here is to understand the root causes of inflammation and begin to address those. And so we've mentioned some of those during this session. So the confusion, what complete health issues should dentistry and oral medicine address? And now, as we begin to answer those questions by digging into the literature, we see that one of the things that's very important is oral pathogens, and how oral pathogens, both periapical and from periodontal leaky gums, can lead to leaky arteries and leaky gut and leaky brain. And these are things that dentistry and oral medicine should directly address with every patient that we see. also seeing that connection between airway, breathing, and sleep, and dental occlusion or dental malocclusion, and temporomandibular disorders and gastric reflux. And then finally, this airway to pathogens to plaque connection, which Dr. Gina and Laura are explaining to us as they've been learning about this and applying it in their clinical practices. So with that in mind, we get clarity. We get clarity on the subject, we get clarity on the relevance, we get clarity on the linkages that we're looking at. And now we want to understand what competencies can come out of this. How can we take this information that's available and begin to develop clinical competencies that actually make a difference in the lives of people every single day? And so what we've done is we've tried to simplify this, and we've simplified it by saying, what are the least common denominators in the connection between oral medicine and whole health? And we found three keys, three pillars as we describe it. And those pillars are: number one, inflammation and infection; number two, airway, breathing, and sleep; and number three, TMD and malocclusion. So if we can focus on those three and begin to really dig in and understand those things and how to implement and apply the lessons that we learn, we can begin to make a huge difference. One of the things that we've learned is it's important to create clinical checklists. Checklists allow us all to do everything at the same level of competency, which is what we're striving for. So if I use a checklist that's very thorough in looking at the three pillars and evaluating history, signs, and symptoms of each one, clinical signs of each one, screening and testing of each one, then we can begin to answer questions. Some of the screening and testing are things that we're developing or that are now available that we're looking at that relate to airway and what's happening during sleep, oral pathogens and which ones are present and at what levels, and then also looking at vascular plaque, which is possible through doing a simple ultrasound of the carotid artery. These tests are becoming more and more used in medicine and in dentistry. Here you see the cover of Inside Dental Hygiene magazine from June of 2023. And what's it about? Salivary testing. And so these things are becoming broadly known and understood as important. But what's more important is to know how to use them effectively and to develop the skills to use them, because these will help us to identify inflammatory cascade factors. These will help us to identify factors of inflamed aging, but then we're going to want to develop competencies, that is competencies in using tests appropriately in our practices, but also competencies in knowing how to interpret these tests and what to do with those tests as far as making a clinical difference. So we also go into treatment options through checklists, and we may have multiple checklists for different subjects, but it's through those checklists and the use of those that we can calibrate all of us together, such that whether we're in California or Florida or New York, we can all do things at the same level of competency, and that's what we're shooting for. And so the objective of our treatment options is, will this treatment modality help to deflame, that is, decrease inflammation? Will it become a part of our anti-inflamed aging strategy? And can we develop competencies in doing these different strategies? So we're going to need to learn a few new skills. We're going to begin using salivary testing and getting results back of various types, showing different levels and presence of the 5 high-risk pathogens. We're going to have to understand what it takes to take them from elevated levels to hopefully negligible and not influencing inflammation locally or systemically. We're going to develop skills that may be involved with things like using laser therapy in the mouth, doing screening of in the office that has to do with sleep issues and sleepiness issues. And so with that, we will develop competencies in doing things like home sleep testing and using simple oral appliances to try to open the airway, and other modalities such as in children doing palatal expansion as well as in adults, and even using laser therapy to shrink the collagen of the soft tissues in the mouth and open up airways. So many exciting things that are coming out. What's our goal? Our goal is to learn these skills so that we can become competent and develop competencies in solving problems. So I want to give you one or two examples as we wrap up this discussion. And that is, here's a patient that came to see us, and she showed up in the emergency room last week, panicked because she had distress breathing and thought she was dying. All the tests were negative, and she was prescribed Valium by the emergency room physician. We saw her in our office as a quote TMD end quote patient. As we looked in her mouth, we saw 5 different signs of airway compromise that could be a key to her problem. We did an overnight home sleep test. It came back that her apnea score was severe, which means that she has a severe airway problem at night and she can't breathe. One of the things you'll find in the literature is that using medications such as she was prescribed, Valium, for severe airway problems like obstructive sleep apnea is absolutely contraindicated. So this patient was actually prescribed something that could potentially hurt her because of a misdiagnosis. Yet here we are in a dental office just looking in the mouth and seeing 5 key signs that we're aware of, that we've learned, that can be important for understanding the problem. Here's a young dentist, and we look at him, some of the problems that he complains of, and we start looking in his mouth, and we're seeing signs of airway problems, signs of dysfunction, signs that could lead to problems of breathing. And as we look at our checklist for him, we see his problem majors on airway and breathing disorders and TMD and malocclusion. Now we've got focus on how we can begin to address this problem, as we see these things are linked to each other. And that's so important. Now we can look at our treatment modalities and begin to describe some of our different options for how we might solve this problem. Many times we have dental solutions for medical problems. And so we'll work in collaboration with our colleagues to do that. Here's a patient who comes in fatigued, tired, severe wear, erosion on his teeth. It looks like he has obstructive sleep apnea. It looks like he may have gastric reflux. He does. Both of those. We work with oral appliances. We do a snore lab study, and we find his snoring goes from very roaring and severe to negligible. We're able to resolve his dental problems. We're able to manage his airway problems with different modalities. We're working on his complete health as well. And we have a very happy camper. And we like to say, on a great day, we save a smile, which we did in Bob's case. But on an amazing day, you know what? We may even save a life. So we move from competence to confidence. And that's what we're shooting for. And so we're very, very, very excited to share with you in this masterclass this transformative journey that has turned our practices straight upside down as we've moved from confusion to confidence. And as we've done that, it's just been so wonderful. And now we're also becoming more and more involved, as we're sharing with you, that there's also another component to this, and that is collaboration. And as we collaborate with our other medical colleagues, we're really able to solve problems that honestly we are not finding solved in very many places at all. And we're beginning to understand that oral medicine is really a foundational part of complete health and complete medicine, and that we are gatekeepers of systemic inflammation, and are so excited to be on this journey and to share this journey with you. So we look forward to learning together, and I thank you for listening to our story and our passion as we look forward to working together more closely in the Integrative Dental Medicine Scholar Society.
We're going to walk you through. We want you to be able to ask questions in the chat if anything arose We're going to kind of walk you through the clarity blueprint here and this level 1 care coordinator. That's actually the first level, is kind of mastering, I say, getting to the point where you're integrating infection and inflammation testing into your practice. And so part of the OASIS program is that you're going to get an exclusive 90-day virtual live masterclass every other week with myself, Dr. Pritchard, and Dr. Wilkerson. So it's going to be exclusive, meaning that once you have access, you'll be part of the community. You'll be able to ask questions. You'll be given challenges. You'll be put to the test to integrate. Dr. Pritchard, this is one of your passions, to do these live classes. What would you like to add about that? Because they're going to have you too every other week with us together.
Yeah, so I would say, in addition to just the education and the understanding of several different ways, none of them wrong, but ways that have worked for you and me and others, that one size doesn't fit all. In other words, we'll give you options as ways to try to implement this in your practice, because sometimes the practice is across the country or across the state or across the city. Sometimes both the oral and the medical practice is under the same roof. And so that we have strategies for all of that. So delivering the content one week in a live educational series, if you will, and then having another session where you can bring cases, you can bring examples of ways you've tried it or that you're thinking about trying it, and we can actually help you strategize and refine what you're doing and sort of lock arms together, if you will. So there'll be one-on-one time, meaning group time with us, where you can one at a time ask us your questions, and we can help you through the content that you just heard and through your attempt to start to implement these things into your practice. And I've been a part of other programs with a similar setup, and I've found it accelerates learning and accelerates getting to mastery.
So that's that whole serious versus curious. Is we're serious with these challenges and just helping you actually take action. It's the action and the steps taking in the practice. So part of that is the ticket to the advanced inflammation workshop that's in person in October. So you get a ticket to that. That is limited. So I just want to say it's, the first couple of people who sign up. And part of that is then being in this elite online community, that you will have access to resources, you'll have access to each other, you'll have access to blog posts, things that you're not going to see any other place. And then we're going to talk about testing made easy. This is something that I feel makes the difference. We're going to be talking about testing yourself, but testing made easy is really about how do we get these tests up and going. It seems to be one of the biggest hurdles that a lot of us have to overcome. And so we're really going to be diving deep and helping you get your testing up and started on both sides. Then we have tons of bonuses. So we have our on-demand foundation seminar bonus, the Essentials of Inflammation course. You're going to get the clarity blueprint. You're going to get all the checklists. We even have secret sauce here, our saliva testing decision tree. You're going to have the GI protocol. We're even going to be diving into some of the medical decision tree in here, even though that's part of level 3. What I want you to hear is you're constantly going to be hearing this and exposed to this information the entire time. And of course, getting clear on what these collaborative tests are. What are the tests and what do they mean? So you can be confident in speaking amongst yourselves, as well as, I'm going to say, the dental or medical side.
Yeah, and it's not going to be required, but we are going to strongly encourage those who haven't had all of these tests on themselves to think about themselves first and get the testing as we go through this process. And we're going to make that easy. And we'll talk more about that in our first sessions. And for sure, we'll talk about it a lot at the kickoff workshop in October 19th and 20th.
So let's summarize, and we're going to open it up to questions. We did today. We'll go to the next slide. Everyone will get this clarity blueprint so that you can understand what that is and what the steps are to walk through. And people ask me, Dr. Pritchard, all the time, how do I start collaborating? And we have a secret person in this community. I would like to unmute Dr. Alan Reisinger. He is one of my biggest secret sauces, so to speak. If I need to find an MD who actually understands, who can collaborate or has the support on the other side, if they haven't come into this community, we have Dr. Alan Reisinger here. And Dr. Reisinger, through MDVIP, why are you my secret sauce? Why do I say that? Where are you?
Well, I've had the tremendous honor of being able to work with Laura on educating doctors, dentists, and hygienists. MDVIP is a concierge medicine group. It's the largest in the country. I've had a passion for cardiovascular prevention ever since I met up with Laura and Gina at a Baldwin conference over a decade ago. Since instituting this method, including the oral systemic connections, I never had another heart attack or thrombotic stroke in my practice over a decade. Well, now Laura and I are traveling around the country, bringing dentists, hygienists, and doctors in the same room to be tortured for about 7 hours on a seminar that really focuses on everything you heard this evening. The docs, the dentists, the hygienists, oh my God, it is so remarkable to see the light bulb go off over their heads and to see them grouping up in the back of the room talking about patients and beginning to collaborate together. So I think the latest statistics are that about somewhere over 700 of our doctors have been exposed to what we're doing, either live or by webinar. We hope to get all 1,200 exposed within the next couple of years. So I hope that we can supply you with some knowledgeable medical folks.
So that is one of my secrets. You can go to mdvip.com, find a provider. You can hound Dr. Reisinger. He will definitely help connect you, and that's why he is part of this community. Again, we want to make it easy. We want to help support you. And in fact, I put Dr. Reisinger on the spot to be part of our next study clubs coming up so that we can hear more about this and we can start connecting across the country, and that you can be aware of when these cardio collaborations are going on as well, to go find your nearest MDVIP, to drag them as I did to the event so that you can sit there together. There's nothing like being in person. So just wanted to share with you, the people in the community. I think that's important, and we'll open up to questions. And I see, Tasia, you are asking, yes, if you already paid for an on-demand course, this is probably the #1 question, so let's talk about it, or registered for the in-person workshop, all of that is credited towards you. There's no additional cost. You get full credit for any of those programs. If you would like to use that towards the OASIS program, that will fully be applied. Anything you'd like to add to that, Dr. Pritchard? Or any other questions on there? Everyone will be receiving the Clarity Blueprint just so you can kind of get your mind around that. Love everyone to kind of on your sign off right now. If in the chat we don't have any other questions, we'll end. You will get a follow-up email with the Clarity Blueprint on there, as well as the link to OASIS and then our upcoming study clubs. But just want to thank everyone, and we are on a mission to build our care coordinators out there to truly collaborate between oral medicine and systemic medicine. Medicine and dentistry are coming together. So I hope you will all join us. Let me know on your way out in the chat. Please let me know where you are. Are you at confusion, clarity, confidence, or collaboration? I'd like to see you sign off where you think you are tonight, and look forward to seeing you on our next OASIS session.
Thank you, everyone, for joining us tonight. Laura, before we leave, I think we ought to just tell everybody that we're calling this the care coordinator levels, level 1, level 2, etc. but it is for everyone. It's for MDs, DOs, nurse practitioners, PAs, nurses, health coaches, registered dental hygienists, periodontal therapists, dentists. It is for everyone on the team, because you never know, one, who's going to arise to the occasion to be the key care coordinator in your office. The whole team needs to be on board with what's going on. And then the dentist and the doctor, while they may not be in this care coordinator role, we all need to speak the same language. So throughout the entire course, we have content for all of those different pieces, if you will. We'll have breakouts that are just for the prescribing doctors, so to speak, and those that are just for the dental hygienist, or just for those that are in a coaching role. And so I think even if you're not sure if you want to be a care coordinator, but you want this in your practice, or you want to learn more about this, just get started and it'll become clear to you if it's your role or if it's someone else on the team. I don't know what else you might have to say about that, or you, Dr. Reisinger, but this is for everyone. But the care coordination is key. Like this person or persons that are actually connecting the dots between the oral and the dental, whether it's in the same office or, as I said earlier, across town, has been a game changer in the practices, I would say.
The only thing I would pitch in is I want to congratulate you all for putting this program together. You know, there's a few handfuls of dentists across the country that are knowledgeable about all of this stuff, and there's a few handfuls of medical docs. I mean, more than that, but the real challenge has been in bringing those people together to collaborate on patient care. And it sounds as though you're going to create a whole network of folks. So kudos to what you're doing.
Thank you so much. I appreciate that. You are our inspiration, you know. You have paved the way with you gallivanting with Laura all over the country and just gonna make it happen. I love your what would the word be? Stamina to do all of what you and Laura have done. Y'all are doing a great job. Yeah. But
I just
the numbers are small, but we want to grow. That's for sure. I'm sorry, Laura, go ahead.
Just Paul's comment. I know you're hearing doctors and dentists. Yes, we are not.
Sorry.
Yeah, no, we say it too. And that's something in this community I want to be open about. It's like we need another definition. We are very aware of that. We even say oral systemic. What does that mean? Like, the mouth is connected to the body. It is systemic. Why we divide that up? And so I do want this community to be open to say, hey, these are things we need to talk about. These are the problems we need to come up with solutions for, so that we're not even doing it amongst each other, that we can come up with a bigger solution, a bigger mission, and really change healthcare. So thank you for bringing that up. We struggle ourselves all the time with this. These are the right challenges to be asking, and good questions. So thank you for that. And I hope we can come up with some better, what do we say all the time, Dr. Pritchard, you know, with Dr. Wilkerson, there's got to be a better way. And so we're going to keep saying that so we can find the best way. So look forward to seeing everyone. Thank you. And we'll see you at OASIS.
Good night.